The following program was produced by an independent community producer. The opinions expressed do not necessarily reflect those of the Weymouth Community Access staff or its board of directors. WCA, in compliance with FCC regulations, is prohibited from exercising control over the content of independent member-produced public access programming.
Hi, thank you so much. We have, and I've talked his ear off already, Dr. Dave Denmark.
Yes.
Is that the right?
That's correct.
Yes.
Yes.
So tell us all about yourself.
Oh boy, that's a long story, but I'll keep it quick.
But you're a new father.
Yes, I'm a new father. Yep.
Daughter.
Daughter, 6 weeks old now.
Isn't that one? You're a lucky man. I have 3 daughters, but boys are good too. I have grandsons.
Yeah.
Congratulations.
Thank you very much.
So you are a doctor.
Mm-hmm.
But you're more than that, is it a cardiologist?
Yes, yes, cardiologist, exactly.
What do you call yourself when you showed me that paper?
Yeah, so interventional cardiologist, which basically means I take care of patients with blockages in the arteries.
What about your schooling? Where were you born? And well, not
sure.
born, but
yeah.
your
No. So I
background.
grew up in southern New Hampshire.
Okay.
And
where is southern New Hampshire? Is it in the
It's
beginning?
kind of like on the border of Massachusetts, about 45 minutes from Boston.
So not too bad.
Yeah, not too bad. Then went down to college down in Atlanta. Came back up.
Did you always want to be a doctor and a cardiologist?
Always a doctor, I think. Yeah, my father was a physician.
Is
and
that
it just
right?
kind of
A
seemed
regular
to go.
physician?
He was a radiologist.
Is that so?
Yeah.
So you went?
So I went to medical school up in New York. Mm-hmm. Then did some more training at Boston Medical Center up here.
Yes, the old Boston City.
Boston City, yeah.
Oh, it's very good
old
hospital.
BMC, yeah, it's great. And then went down to New York for a couple more years of training cardiology and interventional. And now I'm back here. I wanted to come back to Red Sox Nation.
Oh, how lovely.
And,
yes, the Reds are terrible year.
Yes, it was a terrible year, but let's go Patriots.
Yes, they cemented it yesterday.
They sure did.
Now, let me ask you this. You've invested about 10 years of your life studying, haven't you?
Yeah, after college. It's 12, yeah.
12 years.
Yeah.
Amazing. Did you love it that much? You weren't deterred, or you knew what you wanted to do?
Yeah, it was. I mean, I really like it. I think it's a great profession. A lot of you get a lot from it. I love interacting with patients and being able to help them. So it's just really I could see myself doing anything else.
And your wife is a physician.
She is. She's in gastroenterology.
Oh, my mother is probably upstairs clapping. I mean, she loved doctors, as I do. Tell us about the heart. I asked you a lot of questions.
Sure.
What is the heart? What does it do?
Sure. So I actually like to think about the heart like a house. There's 3 main components. You kind of have the bricks and mortar, the walls and the doors of the house, and the house is there just to provide shelter. The heart has the walls and the valves of the heart, and the heart is just there to pump blood.
And it's what? It looks like a...
It kind of looks like a fist. It's about this big. Kind of looks like a football if you were to cut it in half.
Oh, my.
And just a football kind of like that.
Okay.
And it's just the muscles and the valves let it pump blood. The second part of the house, if you will, is the lighting, the electricity. And you have the electrical system of the heart. And then the plumbing and of the building, making sure the pipes and all that kind of stuff are working well. And you have 3 main blood vessels that go to the heart. And my job is to fix the plumbing of the heart. So I'm the plumber of the heart.
Why do we need a plumber? I mean, what do we do that makes us need you?
Sure. So I'll kind of show you this here.
Oh, and I was so excited about that.
Oh, yeah. So
Kathleen, you're going to pick that up, I think.
So this is basically an artery of the heart.
Okay, we'll wait till we get a close-up on that. That is, and Kathleen can, okay, beautiful, beautiful.
So this is what our arteries look like when we're born. 3 layers, nice and smooth.
3 layers?
3 layers of blood vessels.
Okay.
This is what it looks like when we're born. Then as we start to age, you can see a little bit of this yellowish here.
Yes.
That's the plaque buildup.
What's plaque? It's
typically cholesterol.
okay.
So all those controlling your cholesterol and all that kind of stuff, that we want to try to avoid this. We can actually start seeing some buildup like this when we're about 12 years old.
12 years old.
Gets a little bit worse, and this is a blockage at about 50%.
All that food my mother felt.
Oh yeah, tastes good.
Ah, delicious.
But unfortunately, it can then start looking like this.
Can you live if it looks like this?
You can.
But can you function and
So
do?
it all depends. You typically can. What basically is going on is when we're at rest, we have the two blood vessels here. So when we're just sitting here at rest,
Yeah.
we have a certain amount of blood flow going through a normal blood vessel, and then through a diseased blood vessel. So we're at rest, it's no problem, blood's getting through both of them. As we start to exert ourselves, our muscles and our heart need more blood.
Yeah.
So when it's nice and open like this, we can get plenty of blood flow. Unfortunately, when we have a blockage like that, we can't get enough blood flow.
Do we get pain then? Is that what?
That's going to give you the discomfort, the typical anginal symptoms,
pressure. What is that? What makes that do that? The heart says, oh.
So basically, you're not getting enough blood flow. So it's as though the part of the tissue is dying or starving for oxygen. And so you can get typically pain, pressure on your chest. Typically it radiates down your left arm, go into your jaw, into your stomach.
And you shouldn't ignore that. You should call immediately.
You should definitely, talk to your doctors. Yeah,
even if they laugh and say it was not, they won't laugh. Even if they say it was nothing.
Yeah.
You want to be sure.
Definitely. The interesting is because this process can happen anywhere in the body. So this is just an artery, and this can happen in the arteries of the neck and cause a stroke. It can happen in the leg and cause that same pressure or sensation, the cramping in your chest when you walk or exert yourself. You can get it in your legs, and that's called claudication. So this happens anywhere.
And you do it.
Yeah, well, help treat it and fix it, yep.
But you operate and treat it and fix it. You don't say, come on in, I'll operate. Do you treat it first with medication and
Sure,
things?
so a lot of it depends on what we're treating. So for example, the heart, we always try with conservative therapy. No smoking, better
who would
diet.
smoke today in this day
Oh,
and
you'll
age?
be surprised.
I know, I see it all the time walking through Boston.
I once had a patient who was smoking a pack a day. He had triple bypass surgery. The surgery stressed him out so much he started smoking 2 packs a day.
Oh my God.
So yeah, it's
I mean, I love chocolate, so who am I to say? I mean, if you said to me no more chocolate, I'd say end it all.
Seriously.
So, I mean, but is it an addiction? I mean,
yeah, I mean, it's very hard. Most people need at least 7 to 8 times to quit smoking. It's very difficult to do. If it was easy, everyone would just do it.
Yes, yes. I used to say to my grandsons, you see this man smoking, we're going to go all the way around the block so we don't do it.
Yeah.
Just to make, do you know today they both tried smoking? So I said to myself, 17 or 20, I mean, at college campuses,
Yeah.
it's so, what can you get through to say, maybe you think you can't, nothing will happen to you when you're young.
Of course, you're invincible.
Invincible. So do you see a lot of people today that come to you from smoking or from other things?
Yeah, a lot of smoking, cholesterol, diet, exercise, family history is a big
that
part of it.
That we can't do anything about,
Not unless
right?
you're going to find new parents, no.
Yes, and it's true, but today, our parents maybe couldn't have help, but we can.
Yeah.
So what would you do, how would you, after treating people, finally you decide the operating room is the key. What do you do?
So if they fail conservative therapy and they're still getting chest discomfort, I'll bring them into the procedure room and I either put a small tube about the size of an IV. Typically it's done through the groin.
Okay.
Those who've had it before.
Is it a painful thing? I mean, people listening,
yeah,
I mean, numb it?
You numb it up, just like for an IV, it's kind of like a bee sting.
Yes.
So you have a little numbing medication called lidocaine, similar to the Novocaine you get at the dentist. Feel like a pinch and a burn, a bee sting, and that's it. And then you'll put the tube in either through the groin or actually, we're doing it much more frequently, and I actually just go through the wrist. So you can go through the wrist and all the way into the heart.
Through the wrist, how is that possible? I mean, you put something
everything leads,
in,
everything leads right back.
And how long would a surgery take like that?
So that procedure, it takes about 10 to 15 minutes to set everything up, to actually go and take a look at the blood vessels and see if there is any blockage like that. That takes about 10 to 15 minutes.
Is the patient up?
So they're sedated. A little gentle medication kind of put them in a dream state. You wake up in the middle of the night.
No pain.
No, it's just a kind of little discomfort at the wrist or the groin, and once that tube comes in, they really don't feel anything.
What does it tell you? when you look at it?
So we're basically using fluoroscopy, which is like video X-ray. Just like an X-ray is a camera and a camcorder is fluoroscopy. So it's X-rays all the time, and we inject dye through our catheters into the arteries, and we see if there's a blockage. If things look like this, or if they look like that.
And when they look like that, what happens?
So when we see blockages like this, I can put a small wire down that blockage, blow up a balloon to push the plaque up against the wall, and then put some metal fencing in to keep it open. That fencing is called a stent.
Amazing. Now, you don't take that blockage and just take it away?
No, you can't. We haven't determined how to necessarily remove it, at least from the arteries of the heart. And the
Will
legs,
that
we
come
think
next?
we can do that.
Oh, so you haven't done it from the heart yet?
No, we basically push it.
Push it. Will it come back? Will it grow back? Will it grow back? Oh, they want you to.
Oh, yes.
Okay.
So basically, as I mentioned, we're putting a little wire down the blood vessel like this, and then putting a balloon to open it up.
Okay. And a real balloon to?
Yeah, it's basically it's not a plastic balloon you can go buy, but yeah.
And you open it up, and then you.
And that pushes the plaque out, so it looks more like this.
Whoa! And then the stent, is it
a stent?
Stent, S-T-E-N-T.
Stent.
Stent. What does that do?
So that's metal fencing that helps the blockage remain like this.
And will it stay forever?
No. Well, the stent will stay. The stent itself will last thousands and thousands of years.
Amazing.
But the issue is that when we're born, our blood vessels look like this, and then the cholesterol grew.
Okay.
So that process is continuing to go. So even though we collapse it and push it back, there's a risk of that closing back up. So typically there are two types of stents we can put in. The older stents are the bare metal stents, and the newer ones are the drug-coated stents. And those drug stents help keep the blood vessel open for a longer amount of time.
What do the drugs do? The drugs are doing something?
Yes, they help prevent the regrowth of the tissue.
Now, say I said to you, okay, doctor, I'm going to eat terrific, I'm going to exercise. Will that keep me from having to do this again?
Hopefully. Right now, the idea is to help prevent things from getting worse. We can't really necessarily remove the cholesterol, or if you eat perfectly, it's not like it's going to disappear, but it can ideally not get worse.
Okay, all right. So that's one thing. What about
Yes.
the leg or the...
The neck or the leg. So I'll start with the leg. So the same process, the atherosclerosis is what it's called. The cholesterol buildup can happen in the legs.
Amazing,
And typically you'll start walking and you get cramping in your legs, in your calf, even in your feet, depending on where the blockage is. And we can do the same procedure. You'll generally get a test first to see if you have the disease, and that's called an ankle brachial index, or an ABI. And what we do is we put a blood pressure on the cuff, a blood pressure cuff on the arm and on the ankle, and we measure the pressure. If there's a significant difference, that tells us that there's not enough blood flow in the leg. And then we can do other testing, like maybe a CAT scan, to see where that blockage is. And then if there's a blockage, again, just like with the heart, depending on where the blockage is, either you can go through the wrist or the leg, try to open it up. Very much the same way we did in the heart.
How many chances of that of coming back?
So it's kind of the same thing. Obviously, controlling your risk factors, diet, exercise, no more smoking, can help prevent it, but nothing's 100%. So sometimes we do have to bring patients back to help open it up. And similar to blockages in the heart and in the leg, sometimes we've done this a lot, or sometimes the blockage is so severe that a procedure itself can't open it and we have to go do surgery, bypass.
And what does bypass mean? What do you do bypass?
So I don't do bypass. That's done by a surgeon in a whole operating room where the patients are completely knocked out.
Okay.
So
does South Shore do it here, or do you send it into Boston?
Do it in Boston.
Okay.
Yeah, so they do not do. They don't do the bypass of the heart at South Shore.
And what does bypass mean? You're bypassing the heart?
Yeah. So basically, if you have three main blood vessels right here on the heart, and so if you have a blockage right here that looks like this, and I can put a wire down and open it up, that's fine with a stent. But if I can't, the surgeons will take another vessel and kind of loop it around this blockage and put it right in there. They use arteries that are already in your body, either one of the chest, they use some from the wrist, and they'll use some from the legs.
Don't you need them to live, or you can take them out?
You can take them out. Sometimes you can, sometimes you can't. In the wrist specifically, there are 2 arteries that give blood to the hand. So as long as both of them are working, you can generally take one out. So you'll still get enough blood to the hand.
And how long can you live with that? Do you have to go back in again with that, or is it?
Hopefully not.
Hopefully not.
Yeah.
Is it a big surgery? Is it a?
It is. It's typically anywhere between 5 days, 7 days in the hospital, and then several weeks to months of rehab. It's a significant surgery. It's open heart bypass surgery.
And what are you limited to what you can do afterwards?
In the immediate post-op period, there's a bit of recovery, but really after that, no. You should be able to do everything you were doing before. The whole idea is that you feel better. You don't have shortness of breath or chest discomfort, and you can do what you want to do.
Are people frightened of going back to their old, of working out and? You know.
Sometimes they are. You know, they're a little concerned about, you know, how quickly can I resume my activities, and I tell them, you know, I wouldn't leave the hospital and run a marathon the next day.
Okay.
Take it step by step, really slowly work your way up, and then again, just kind of be aware of the symptoms. There is generally a symptom that brought you in, either shortness of breath or chest discomfort. If you start noticing that,
can you have that happen again?
You can. Mm-hmm.
You can.
Yeah, it's not 100%.
How long was the heart made to live and run?
Oof.
Forever?
I mean,
what forever is a funny term. I mean, it's forever 80 years or 20
right, exactly.
years?
But yeah, there's no like timetable. As long as you take care of yourself, it should keep on ticking. But you know, if we could find a way to keep it ticking forever,
yes,
that'd be great. But generally, it's disease in the electrical system,
yes,
or the plumbing,
yes,
and then sometimes the muscle just gets weak. You know, it's just the muscle, just like any other muscle. You go to the gym. And, I can, you know, bench 10 pounds forever, but I probably can't bench 10 pounds for 100 years.
Yes.
And the heart gets weak and tired.
Even though you're helping it to be stronger.
Mm-hmm.
Yeah, well, everything wears out and goes.
It does.
So when I see a man in the gym with this belly hanging out, I think to myself, and you're really bench pressing a lot.
Yes.
Doesn't mean a thing. I mean, he's bench pressing when he has this big gut that is sort of hanging.
Yeah, so he's probably, I mean, if that's the case, he's probably, you know, doing great with the arms, but not so much
with the diet.
Exact diet and exercise. A lot of
what do you recommend?
So at least, ideally, 30 minutes a day, 5 days a week.
Isn't
as far
that
as exercise,
wonderful?
Yeah.
Huh?
And again, it's little things I think can make a big difference. For example, if you're in the mall, you see the escalator, take the stairs.
That's right.
You know, no more elevators. If you want to go down a flight or two, you can take it.
Yesterday at the tea, I took all the stairs. I'm thinking,
Excellent.
You people in the escalator, not a good idea.
Yeah.
So it's true. Those little things you can.
Little things.
And when I'm waiting for the train, I walk and walk and walk.
Exactly.
People look at me, but I'm getting my walk in.
You go to the mall, people will take 20 minutes to try to find the spot right near the door.
Yes.
Park in the back.
Yes.
Walk in.
And 20 minutes of walking would be wonderful.
Exactly. So those little things can really help.
And what about diet?
So diet's the same thing. I generally recommend what we call a heart-healthy Mediterranean diet, which is a lot of fish, chicken, fruits and vegetables, but anything in moderation.
Okay.
You know,
what about a hot fudge sundae once a month or something?
Sure.
Yeah.
Sure. You know.
But basically a very good.
Yeah, a well-balanced diet. And then again, for people who are trying to lose weight, I advise them little steps, little things such as you have a big plate of food there, cut it in half. Eat half your food. Drink empty calories, a lot of water. Get rid of sodas, stuff like that.
They're really saying bad.
Sodas are no good. But I'll replace that personally with flavored seltzer. There's a little flavor, a little
Perrier.
Yeah.
If you have the money, Perrier is very, very lovely. Lime, grapefruit they're making. But why not? I mean, something. I love those. And Stop and Shop puts out a good one, Zaz. I think it's their Polar.
Okay,
And Zaz is nice too. Different flavors. Mm-hmm. Yes. It's so hard to change and get away from habits that are so ingrained.
Yes.
And exercise. So is strength training good too?
It is. I mean, definitely strength training, bench press, all that kind of stuff. But it would be, I mean, at least better from a heart perspective.
Is the diet
more cardiovascular? Well, even more running.
More running.
You know.
I was a runner 15 years.
That's great.
Runners. Do you know that James Fix, I think it was, who was a runner for years, had a heart attack running. And in this day and age, they were saying he didn't even realize that he could have been, taken care of by a cardiologist. Sure. running. Isn't it wonderful to run?
Yeah, it's great.
It's really lovely.
Yeah, I try to. You know, it's a little harder now with the baby at home.
Yes, that's true. That's true.
Now in my spare time, I just try to sleep.
I see when I go through Boston, doctors running to work. Sure. You know, they have a backpack. I mean, you never saw that in my early days. Running, or you could go by Beth Israel has a gym. You could see all these people on it. Does South Shore do that now?
That's a good question. I'm not sure.
Okay.
I'm not sure if they have like a.
But look at the shape you're in. I mean, I suppose you would. Do you try, or it comes naturally to you?
A little bit of both.
Okay.
You got to try. And again, it's with diet and exercise.
Yes.
And then hopefully, you know, healthy eating at home and all that kind of good stuff.
Now, people watching at home, what other heart conditions or something you would work on them for? Would they be interested in?
Sure. So we kind of spoke about the heart and the legs, and the other blockages that people are really concerned about are up in the neck.
Okay.
And so when you typically have blockages in the neck, you can get a stroke. Or a mini stroke, which is what we call a transient ischemic attack, or TIA. Typically, patients they may have slurred speech, blurred vision, like a shade coming over their eyes. You may get weakness in your arms or legs. Sometimes that'll go away in 24 hours. If it persists, it's considered a stroke. If not, it's what we call a TIA, or a mini stroke. And that can be due to blockages in the neck.
Are women more vulnerable? Because women never talk about heart disease, but do they not have heart disease more than men?
I don't want to say necessarily more than men,
okay.
but the interesting thing is that women present what we consider now as much more atypical. And the reason we say it's atypical is because we looked at all the studies. You go back, well, how do we know that when I have chest pressure radiating to my left arm, that's from my heart? Well, we took a whole bunch of patients, and we looked at their symptoms, and we found out what they have. Excuse me.
I think it's wonderful. Do you have to take
No, not at all. We looked at what symptoms they have, and when we go back and look at these patients, 90% are men. Just the way the studies were done. So we say women present atypical. It's not that necessarily their disease is any different, but just that in our studies, the majority of it were men. So women can present with much vaguer symptoms of chest discomfort. Maybe they don't even feel any chest discomfort. It's just some pain in their left arm or right arm, something up in the neck. And one of the interesting things is that diabetes, which is basically what we call a coronary risk equivalent. So if you've had a heart attack, you have a very high risk of having a second. If you haven't had a heart attack but have diabetes, you also have a very high risk of having heart disease and having a heart attack. So in patients who have diabetes, especially when it gets advanced, can affect the nerves. So you don't necessarily feel your chest pressure or pain or pain in the legs when you're walking. So in diabetics, we're generally more aggressive with medical management and screening techniques to try to pick up disease earlier. And
what are some symptoms that diabetics should look at?
Thirst or? Well, exactly. If you have new onset diabetes, it's increased thirst. Is typically one of the things, urinating a lot. And generally, you'll when you see your doctor for physical, they'll check your blood sugar,
and that will tell.
And that should typically tell. But you know, as far as from the heart and the leg and the necks and blockages there, diabetics could have those symptoms, or they can also have no symptoms. And so that's why we typically screen them earlier. So for example, in patients, when we're looking for blockages in the legs, which is called peripheral arterial disease, or PAD, the screening, that ankle brachial index I was mentioning earlier, we can consider doing that in any patient who is 50 years old with a history of diabetes, or if they're a current or former smoker, and then any patient who's over 70. You can consider screening.
And the screening is done?
Is done in the office, and it's measuring the pressure in the ankle and the arm, and seeing if there's a difference there.
So people want to see you specifically. They have to. Can they call you, or do they have to go through another doctor? Or?
Sure. So I mean, they can always call the office, and I'll be honest with you, a lot of it depends on their insurance.
Okay.
Sometimes the insurance requires that they get a referral from their primary care.
I know.
And sometimes they can just go directly to the specialist.
Oh, I know. That insurance is, well, I don't need a referral anymore, so I'm delighted.
Perfect.
But you were saying there are 70, is it 70 cardiologists?
In our group there are about 70 physicians total.
Isn't
and about
that
10 cardiologists.
And 10 cardiologists.
Yeah,
and your group is what?
A Harbor Medical.
Is that the way groups are going? Is that no doctors are really out on their own now? Is it groups? About 4 minutes.
Okay, perfect.
Is that the way? Because I see it with my own physician.
Yeah, a lot of groups are joining to really have more bargaining power with the healthcare.
Boy, they need it.
Insurances, yeah, and again, a lot of hospitals are kind of, buying practices, and it's the way things are going. There's a lot of benefits to it. Sometimes you'll see a doctor right away because they're in your same group.
Yes.
So there are some pluses and minuses, but a lot of people are joining forces.
And what about the hospital itself? You operate at South Shore?
Yeah, so I do procedures, primarily see patients at South Shore, and I also do some procedures up in town at the Brigham.
Do you really? Mm-hmm. Do you think South Shore is really advanced? I mean, we're doing a lot.
Yeah, it's great. I think a couple months ago in the U.S. News and World Report, South Shore was tied for 3rd in the entire state of Massachusetts for best hospitals. I think it was, I can't remember, it was Mass General and the Brigham, and then Beth Israel and South Shore were tied for 3rd. Yeah.
That is wonderful.
Yeah.
And look at what's happening. People with your talent are operating in Boston but going to the suburbs because that's where people are branching out.
Yeah. Well, no one wants to,
go into Boston.
Yeah, who wants to take 93 all the way to Boston, right?
But here we have a wealth of people like you. How marvelous it is that your father was a physician. You always wanted to be a doctor. You've given 12 years of your life to study to help people.
Yeah.
I mean, that is a lot of effort and time.
Sure.
What would you leave viewers with? What should they do? Anything they should adhere to or listen to?
Sure. I mean, I think as far as the heart and atherosclerosis, the biggest thing is healthy diet, exercise, no smoking, follow up with
2 minutes. They're just telling me. Thank you.
And if you have any symptoms, don't ignore them. See your doctor. A lot of patients kind of think like, oh, I'm getting a little bit older now. It's okay that I get chest pressure. It's okay that I get some shortness of breath. It might be. Sometimes we get old. Sometimes these things happen, but a lot of times you realize it's kind of too late. And I'll also make a point that, this disease, atherosclerosis, doesn't just happen when we get 60, 70, 80 years old. I've done plenty of stents, plenty of procedures in 30 and 40, 50-year-olds.
Have you really?
Mm-hmm. The youngest person I did was a 32-year-old female.
32? Was it genetic or she?
So she had a lot of risk factors. She had diabetes, a lot of family history. So family history is key. A lot of people who present early will say, oh yeah, my father died from a heart attack when he was 40. Well, that's when you want to be seeing your doctors in your 30s, earlier than you think, to get screening and make sure you look for some heart disease and disease in the legs and the neck.
So in other words, don't ignore symptoms. We have 1 minute. You are terrific. I hope you will come and visit us
I'd love to. It was great.
And the heart is the major thing.
Yeah, if it's not working,
goodbye.
It pretty much is. Yeah, it's you don't have too much of a second chance with that.
And I was just reading that
you can do stents in the neck, in the carotid artery, sure. But typically, they prefer surgery. It all depends on the patient.
I thank you. So I heard that years ago your lifespan was maybe 59, 60. Now it's up there.
Yeah. I mean, well into the 70s, 80s. We did one patient who was 98. They went for open heart surgery for a valve, and she recently celebrated her 101st birthday.
Is there more risk factors of that? I'm sure we have to go, but
sure.
Thank you. Oh, whoa.
It was a pleasure.
A pleasure. Thank you. Thank you so much.
You're welcome.
Bye-bye for now.
Take care.
And